Okay, so I'll go ahead here. Hope we should be able to get to some other questions as well. I did want to talk about monitoring recommendations. So again, this is from the international guidelines that came out in 2017. This is the recommendation for checking that red blood cell galactose 1 phosphate in blood. They're suggesting you do it at diagnosis for sure. 3 months, 9 months, yearly after that until there's a baseline that has been established for your child or yourself. Some people will have higher galactose 1 phosphate levels and they just run higher, like 4, even 5 milligrams per deciliter. Other people might run in like 2 milligrams per deciliter. So everybody seems to have their own baseline. And so once you hit that baseline of, and you know kind of what it is, they're not emphasizing measuring that red blood cell galactose 1 phosphate as much as they used to. Studies have shown that there's little correlation between those galactose 1 phosphate concentrations and those long-term clinical outcomes that I talked about. So again, I would say clinics are not measuring this as often, again, once it's stabilized. It may have a value if you're trying some of these foods for the first time that might be on that moderation list. You can check it, the Gal1P, before you start that food, then eat it for a few days, check the Gal1P again. If you're seeing a big spike up, well, that might tell you that's probably not something you want to eat. But that's really about the most valuable part of measuring red blood cell Gal1P after you've kind of established that baseline for each patient. About bone health. So patients with classical galactosemia are at risk for impaired bone health. The reasons why are the restriction in dietary intake. We get most of our calcium and vitamin D from dairy products, so we're taking those away. That increase the risk of problems with bone. Decreased physical activity in some patients, some just are not as active, and there is a correlation between activity and bone density. Certainly in females, the ovarian insufficiency can cause changes in the estrogen levels, and estrogen has a big role in calcifying bones. So if females are on hormones because their levels are low, then that reduces that risk. But if not, there is correlation between the females if they have low estrogen levels and are not treating it, and that increases the risk with poor bone mineralization. There's likely other factors that they're looking into, not 100% clear why this is happening, but certainly these patients are at risk. I just want to go through a little of the bone basics so you kind of have an idea of what's going on. So when bones are forming, the first thing that happens is you lay down collagen, and then that collagen is mineralized, meaning that calcium, phosphate, other minerals are adding into that collagen. And bone is, we don't really think of it as having metabolism, but it does. It's all at all points in time. We're forming bone, and the type of cell that does that is called osteoblasts. And then we're also breaking down bone, which is called resorption, and that's done by a certain type of cells called osteoclasts. So this is just kind of the bone cycle. Here you have over here, these osteoclasts. What they're doing is they're demineralizing areas in the bone, forming this pit, I guess is a good way to describe it. And then the osteoblasts, those are the ones that mineralize bone. They will come into that hole in the bone and start mineralizing. This happens again all through the lifespan. The difference is that during growth, that formation by the osteoblasts exceeds that resorption by the osteoclasts. And that formation is greater up until you hit a point which is called peak bone mass. So you're gaining bone up to this point where you've got this peak bone mass. And then in most individuals, bone will start to be lost at a faster rate than it's being formed. So this peak bone mass, it varies for individual to individual, but it's usually achieved around age 35. It's influenced by exercise and nutrition. So we as dietitians really emphasize the fact that bone mass is really increasing in childhood, adolescence. That adolescent growth spurt is very important. And you need to have enough calcium, phosphorus, vitamin D at that point to put as much calcium into those bones so that when the resorption is greater than the formation, you have more of a store so that your bones stay stronger for longer after you kind of hit this peak bone mass. These concerns about bones, not all individuals with galactosemia will have poor or lower bone density. The way you pick this up is by DEXA scans. And that can show the mineralization level of bones. Some studies have also shown lower levels of different growth factors and enzymes that are related to bone formation and resorption. I just listed a few of them there. So again, some clinics will measure some of these enzymes or growth factors to kind of give an idea of how a person's bone calcification and bone density is. Again, DEXA tends to be the big thing that is measured. However, these growth factors, enzymes tend to be more on a research basis. So these are different risk factors. Again, that's hormone differences,